morning. Welcome and thank you for attending today's session with William Fewer on approaches to treatment family therapy. Before I introduce Willard, there are a few housekeeping tips. All sites have been muted at the bridge, but please be sure that your mics are also muted. If you experience any technical issues, please let your local site contact know and they will follow up accordingly. If you have any questions for the presenter during the session, feel free to email erin.day@gov.ab.ca. And that's Erin, E-R-I-N. If you have questions for the presenter after the session, his contact information can be found at the back of your handouts. Evaluations for this session will be emailed to participants, so please be sure to sign the attendance sheet. We are pleased to let everyone know that today's session has 40 sites attending. There are over 10 participants at our live site and many more video conference participants today. Education and training is a critical aspect in the Government of Alberta's FASD 10-year strategic plan, and that is addressed through various initiatives such as the video conferencing learning series. We are pleased with the ongoing interest and attendance in this initiative. Now I have the pleasure of introducing Willard. Willard Fewer is a registered psychologist and a registered marriage and family therapist. He has worked with families in a variety of settings for over 20 years. Willard has provided family interventions in a variety of settings, including home-based therapy, family preservation programs, and children's mental health programs. Please join me in welcoming Willard Fewer.
Thank you. So this morning, as I was watching the sites sign on, I felt like I was taking a little tour of Western Canada. It's good to see people from the variety of locations that you're signing in from today. Back several months ago, someone asked me if I would do a talk on family therapy and FASD, and I kind of scratched my head and said, what could I possibly say about that topic? So I did a literature review and realized there was nothing I could say about the topic because I found next to nothing. Actually, initially I found nothing, and eventually I found a very little bit that has been published over the last few years. There's three items that you'll see at the end of your package, your handout today. So then I started thinking, have I done much family therapy with families that are affected by FASD? So anyway, I started reflecting on my own practice, and I came up with 3 adolescents that I've worked with over the past 5 years or so that I really want to talk about a fair amount today to illustrate some of the points that I want to make in the presentation. So I'll just start off by talking about each of those and tell you a little bit about what brought them to come and work with me. John, who was 16 at the time I started working...
Calgary, please turn off your mic.
John, who was 16, came to me referred by his child psychiatrist. John was adopted from another continent with his older sister. He presented with attention problems, low intelligence, severe anger outbursts, and also a lot of anxiety. He had been tried on a variety of medication regimes, a lot of creativity as well as the usual things that psychiatrists start with, and he'd shown really poor response to the medication. John had quite poor expressive language. He had speech difficulties. He was very, very difficult to understand. He used a bit of his own sign language at times. He was engaging in some sexual acting out at school and at home with male peers, which had his parents really quite upset. His father was quite depressed. His mother, we eventually learned, was mildly depressed, and his sister received some treatment for depression eventually also. So that illustrates why the family approach too, because what was happening with John was clearly affecting other people in the family. Tom was another boy, an Aboriginal boy, who was 12 years old when I met him. He was living with his biological mother, 4 siblings, and with his stepfather. Tom presented with extreme anxiety. He was selectively mute at that point. The only responses I could get from him in the assessment were whispered answers to my questions. He was trying to comply, but he really had no voice at that point. somewhat like me earlier on today here before I started raising the volume. He was living with a stepfather who was quite harsh, who had his own quite significant compromises. He was in and out of jail for doing what I technically referred to as boneheaded acts, like trying to pass rubber checks and some petty stealing and things like that. In addition, Tom presented with attention symptoms. He had auditory hallucinations, and he was very obsessive and had a real fear of dogs at that point. The neighbors had a dog, and he was actually terrified. He'd have panic attacks whenever he saw or heard a dog. He was quite defiant at home. He had attacks of rage, and at school he was mostly shut down in that he didn't talk and he really didn't do very much work. The third individual that I want to talk about a little bit through today's discussion is Tina. Tina was 15. She was an Aboriginal girl who was adopted by an older professional couple who worked in the healthcare system. I'm trying not to give too many specifics here because I want to maintain confidentiality about these folks. Tina's adoptive parents they had each raised a family of children on their own, and now they had remarried and they were raising Tina. Tina had average or greater intelligence. She was quite a sharp young lady. She presented with ADHD symptoms initially. And as she got a bit older, she started showing a great deal of defiance towards her parents. There was some sexual acting out that started when she was around 14 or 15, and she started experimenting with marijuana once she started high school. And she had a line that I'll never forget. I was talking to her about some of the sexual acting out by herself at one point, and she looked me in the eye and said, "What's a sexually confident young woman supposed to do?" It was just so shocking, and I just started laughing, and we actually were able to have a discussion after that I think was helpful to her and her parents. So let's move on after we've introduced those three kids and start talking about types of families who are affected by FASD and some of the issues affecting the families. And I think we've started illustrating some of those. Some of the families that I've worked with the children are being raised by their biological parents, Tom being an example of that. There are adoptive families, and certainly Tina and John are examples of that. And there are foster families who are raising kids with FASD, and they sometimes benefit from some family support and intervention. And the fourth type of family is grandparents raising the children of their own children. So let's talk a little bit more about the biological parents and their children. Some of the things that we need to be aware of is there are lots of feelings connected to having negatively affected your child's development during the pregnancy. Lots of guilt feelings, perhaps being angry at themselves, maybe angry at the whole world because it feels unfair that they now have to raise a child that is really compromised and is quite difficult a lot of the time. There may actually be current addictions or struggles with mental health concerns. And there may be difficulty trusting and working effectively with some of the professionals. And certainly some of the families that I've worked with where the biological parents are raising the children, FASD has been identified somewhere along the way for one or more of the parents. So in Tom's case, his mother had told him while he was an adolescent that she had drank during the pregnancy. He came to me in an individual session and said, "I'm really upset because my mom drank, and that has made it very difficult for me to manage in life." He said that in his own language, but he said it quite eloquently for a boy who with the struggles that he has. And we decided that we would do a session with him and his mother, and they were actually able to make use of a therapy session to talk a bit about that, get some clarification. And ultimately, Tom let his mother know that he didn't hold that against her, that although he wasn't happy about it, he wasn't angry with her about it either. In Tom's case, his mother also made some really unhealthy choices in terms of her male partners. She had a series of male partners who were abusive towards her, and although I never had any strong evidence, my suspicion was they were abusive towards the kids at times too. And in Tom's case, the choices seemed to be either child welfare would be involved with the family or I'd be involved with the family. And needless to say, child welfare preferred me to be involved with the family. It seemed to help stabilize things, and Mother was able to manage with the children better when she and her sons were coming for therapy. And like many biological parents who've had their own troubles, Tom's mom had a very difficult time learning to trust and to actually disclose anything other than a one-word answer to a question. But eventually she was able to develop some trust and engage in the therapeutic process. Let's turn to a little bit more about Tom's mother. She suffered from depression. She wasn't receiving any treatment for it, but she was quite obviously depressed. She had scars on her arms from cutting herself. She never spoke much about her own childhood, and when she was asked, she tended to speak of it in positive terms. But it was pretty apparent to me that she had grown up with lots of difficulties herself. 4 out of her 5 children appeared to have some significant compromises and mental health issues, and the family was struggling with poverty. So those were all issues that, to some extent, we were able to address in therapy, but to some extent we never did address fully because of where Mom was at. So let's turn to talk about adoptive families at this point. So John's parents had adopted him and his sister. They weren't able to have their own biological children, so they adopted children from out of country, like many families do when they have difficulty conceiving. When they presented, John's father was really struggling. He was really finding it very difficult to cope with home life, and that was really affecting his work life. He was experiencing chronic depression, and his initial goal was to place John out of the family. John's mother, on the other hand, was really unwilling to have John placed elsewhere. Both parents clearly were struggling to come to grips with the loss of dreams for the child that they hoped to have adopted. Certainly, John created embarrassment in their lives. It was difficult to have friends over to visit because John could be very difficult in the home. And certainly taking him out in public, he could create scenes also. So that was a challenge for them. Frustrations when John became anxious and defiant and wasn't able to cope. And I think his sister experienced a fair amount of emotional harm from the whole process, and I believe she was lost in the process, lost in the dust when John was acting up, because the parents were just overwhelmed and unable to really attend to her needs very much. Often when people adopt children, they have a belief that their love will overcome any kinds of troubles. And the good thing about that is they care for kids who need families. But the downside is at some point they have to realize it takes a lot more than just love to raise a child who has some serious compromises. Tina's parents initially denied that there were any serious difficulties with her. They believed that she was acting bad. When she was diagnosed by ADHD by myself and the psychiatrist, they had a hard time accepting that. Ultimately, they did accept some medication, and it made a little bit of difference. But it took quite a bit of work with those parents to get them to a point where they could make good use of our services. They had been successful raising a number of other children earlier in their lives. And at times they really struggled with, maybe we should just give her up. Maybe we're unsuccessful as parents. Our lives would be better. They were near retirement age. So they struggled with those kinds of things. And I think that is a common struggle for adoptive parents, is they fear that they aren't the right parent to raise this child. And sometimes biological parents really struggle with that too. Am I good enough? How do people see me as a parent? Those kinds of thoughts. So let's talk a little bit about foster families at this point. that was the area of fostering was actually one of the areas where there was a bit of research by Patrick Morissette, and the references is in your package. He developed a number of themes. He interviewed 6 or 8 foster families and did a qualitative analysis of what they told him and came up with the following themes. So constant vigil was one of the themes that the foster parents talked with him about. And that involved things like protectiveness towards their children, protecting them from exploitation and physical harm. And I'm reflecting on one of the foster families I worked with. From the outside, it looks like they're overprotective. It's not till you start to understand their thinking and what they live with from day to day that it starts to make more sense. It doesn't necessarily mean it's still developmentally appropriate, but it starts to make more sense when you understand the child and what's happening at home. So an example in one of the families I've worked with recently is there's a rule of no dating until, I don't know if it's 18 or 16 or I don't know what it is. And I joked with the teenage daughters that with my kids it was still you're 35, but they didn't find that as funny as the parents did. Another example was one of the children is not allowed, or one of the teens is not allowed to use knives or stove. I was asking who's going to cook meals while mom's away, and she said, I can't do that. I said, why? Because I can't use knives and I can't use the stove, which sounds kind of crazy for someone in their teens that you would allow them to work in the kitchen. But she's also someone who is impulsive and who can harm herself accidentally. Another theme was hypervigilance to the behavior or location of the child. So when you've got a child who's unpredictable and can repetitively get themselves into the same kinds of scrapes, it trains you as a parent to keep an eye on them and to kind of hover. At the same time, when the child becomes an adolescent, a lot of people around tend to judge the parent for doing that and thinking that we've got a parent who's just too anxious. Another theme was the stress on the marriage. Raising one or more children with special challenges can be really stressful for marriages. I was trying to look up statistics because those of us who work with families get this sense, and with kids with disabilities, get this sense that there's an extremely high divorce rate. So I did a Google on that recently, and what popped up was a rate of 80 to 85% marital dissolution for families raising a child with autism. And then I looked at some of the other things that popped up in the same search, and there was all kinds of debate about where that statistic ever came from, because nobody apparently can say where the number came from. So there is debate, certainly from our own experience. It appears that the divorce rate is much higher when you're raising a child with a disability, but we don't have clear statistics that either support or refute that sort of notion. Some of the marital challenges are how to be supportive to your partner, because often parents will have different opinions on what the appropriate response is to the behavioral or emotional difficulty that the child brings to the family home. How to keep the partner as your primary relationship in the family. Often the focus all becomes on the child, and it's difficult for the parents to feel like they're cared for by their partner. And it's also very difficult sometimes to find the time and energy to devote to the marriage, all of which I think are really important priorities that we need to work with the parents on in family therapy. And another issue, and when we're looking at marriages, is the tendency, especially for men, to isolate themselves when there are troubles in the home. So they work late, or they go out to the garage and work on handyman kinds of jobs and avoid the difficulties in the home, which makes the parent who's left to handle things somewhat resentful often. And the final thing in terms of marriages is to work on the unresolved conflict, because sometimes it's easier to walk away and not resolve that conflict, which makes the next time it comes up even more difficult. One of the other themes that Pat Morissette came up with was the area of child management. So the parents identified several different areas that were important there. One was manipulative behavior, the tendency of the child to opinion shop. So if mom says, no, you can't go out, they'll go to dad and ask dad whether that's possible or whether that's okay. Or tell dad, mom says it's okay, is it okay with you? Those kinds of manipulations. Sometimes kids would comply in words but not in behavior. So, I mean, those of us who work with families see this all the time, not just with kids with FASD. But it's an important area to consider when you're working with families. Unmanageable behavior. So when we look back at John and Tom, they both had huge rages at times when they couldn't function, when they couldn't cope with what they were facing. Those were very difficult times because things got broken in the home. People were scared, and parents felt out of control too. And sometimes the parents escalated their own anger and felt really bad afterwards. Kids sometimes run away in these kinds of situations. And Tina would be an example of that, where she would take off when she was upset with mom and dad. Once again, very scary when you've got a teenage daughter who's angry with you and who's taken off, and who knows where she's going to end up. And the whole sense of out of control in the home. Walking on eggshells is kind of a phrase that I sometimes hear from families where someone has these kinds of difficulties. Another area in terms of child management is children and teens often are able to disguise their disability. So professionals or people at school or in the community see a normal child who may have some small difficulties, but they don't see the magnitude of them. And the tendency then is to blame the parents. So I had a caseworker ask me if I thought that we were dealing with a case of Munchausen's by proxy in a situation not too long ago. And from the outside, it looks like that might be a possibility, but when you do family therapy with them and some of the stuff gets acted out in the family therapy, it has a lot more credibility than if you look at this child in the classroom who is able to manage in a highly structured classroom with a teacher who's really organized and is able to be sensitive to the child's need. Another area that the parents identified was the importance of sequences and routines. It's the comfort in predictability. Teens often don't like the structure, but they benefit from the structure. Kids with FASD sometimes get very anxious if you alter the structure. So an example that was given to me is if I drive home a different route, she gets upset with me. And, that doesn't make a lot of sense to us unless you're raising a child with FASD, who any change from the routine can be upsetting, anxiety-provoking, and can ultimately lead to meltdowns, or if not, at least tension in the family. Further area that Morissette and the foster parents identified was parental issues. So a foster parent who's starting to work with kids with FASD, unless they've had some good training, and maybe even if they've had good training, it doesn't sink in until it's in front of you and you have to actually practice it. So the ability to do good work with these kids develops over time. Parents need support from professionals. They need to learn what's realistic for the child and what's unrealistic. Huge energy demands on parents. That vigilance, that protectiveness can be really draining. And the walking on eggshells, trying to avoid severe conflict with kids who are easily triggered is very difficult too. And the real need to be consistent and persistent. Certainly we know kids with FASD can have very big difficulties with learning from experience. So the experience have to be repeated over and over again, and hopefully with that consistency and the persistence on the part of caregivers, it starts to sink in eventually. And then another area that they identified were emancipation concerns as the teen is reaching the age of 18. There becomes the question, what's going to happen now? So as a foster parent, you may have had this teen for several years, and the system may not provide continuity of services, certainly in the way that you as a foster parent believe is necessary. And once again, with the child being able to manage to disguise their disability in a variety of settings, and it may not be apparent the kind of supports that will be needed in adulthood. I guess one of the things that Dr. O'Malley talked about when he spoke in the spring was, I think the figure he gave was 75% of kids with FASD have normal intelligence. And we tend to put services into place for kids who have very low intelligence rather than those with adults with average intelligence. Even though Tina was a very bright girl, she made very bad decisions for herself, put herself at severe risk, and had a great deal of difficulty managing the sorts of things you'd expect an adolescent to manage. Things like handing in assignments that were completed beautifully but never got handed in. So important to plan for supports after emancipation. And the final area that foster families identified were the medical implications. So many kids with FASD also have some chronic medical difficulties that require lots of medical attention. I know there's a little boy that I'm currently working with who's very young, but he sees more professionals in the course of 6 months than I've seen in a lifetime, I'm sure. That creates a lot of challenges for the parents who have to come from rural Alberta to Edmonton to see the specialists on a regular basis. And certainly, if that little boy, he has some lung conditions, and if he gets a bad cold, it's not a bad cold, it's potentially life-threatening. So that adds another layer of stress and anxiety for the parents. And let's turn to the area of grandparents who are raising their FASD-affected grandchildren. So some of the things that in my experience are reported is a sense of fatigue. They tend to be older parents. They're tired. They've got this child who's very difficult, who may have far more energy than any child should have. Way later in the day, they feel like they never get a break. They've raised their own children, and now they're raising another generation. It's very difficult for them at times. Often resentment towards the child who's not taking the responsibility for raising the grandchild, and maybe even worries about what that adult child is, how they're conducting their life at this point. Maybe addiction issues, or maybe other serious risky behaviors they're involved in. There also may be feelings that they're reminded of having failed in some sense as a parent when they raise the adult parent of the child they're raising. And certainly most of those challenges that I talked with you about earlier on would apply to the grandparents too. And I think sometimes the grandparents are doing this not out of choice, but because they see no other choice for their child. They don't want to give their child up to the foster care system or group homes, so they're doing their best. But they may not be all that motivated to learn new ways of managing. They may be trying the same parenting strategies that may or may not have worked with their own children in a previous generation, and not all that open sometimes to suggestions we have. Now, that's not universal, but that's been my experience sometimes. So next, let's talk about some family interventions that can be helpful. And certainly the first one is the whole idea of education and training about FASD. And here in Alberta, we've certainly had just a real burst of availability of information for professionals and for families on what FASD is about, and to understand not only causes but ways of working with kids and teens who are struggling in that area. Some of the things that I've certainly been aware of in my work is the difficulty with executive functioning in the children, and certainly in the parents too sometimes. That's the ability to think before you act, to make plans, choose how you're going to respond to situations. So I got a mom who's kind of driving me crazy by calling me several times a day lately. I don't know if FASD is a factor in this case or not. It may or may not be. But she has decided that it's not working. She has the tendency to want to fix it right now. So she's impatient. She's very impulsive. She will. You give her a suggestion and it happens right now, but she doesn't think it through in terms of the implications, and she doesn't discuss the implications with you. She just wants to get at it and fix it. Her main strategy for managing the child is yelling. And I had a session with her by herself not too long ago, and she decided in the middle of the session she needed to call her own dad, and there was no stopping her, so she called her dad, and her dad proceeded to yell at her over the phone for 5 minutes in front of me. And I said, I know where you get that from now. And what does her son do? Her son yells at her. So the executive functioning stuff hasn't been functioning very well in that family. And certainly with kids and teens with FASD, we need to slow things down so people can start to think as opposed to react. Need to do things to reduce anger in the family. Family is often very discouraged, very angry with each other. The parents are angry at the teens and vice versa. Right now? Okay. I've been told we're going to take a break for about 3 minutes right now, and we'll pick it up after. Okay, thank you for your patience. We've kind of reset the room here. Hopefully you can hear me better. Apparently the microphones that were closest to me weren't working. Okay. And now to remember where I was. So we're talking about, I think I talked about the difficulties with executive functioning in the child and sometimes in the parents. And I think I was just starting to talk about reducing anger. The level of anger sometimes in families when I start working with them is at such a level that if you don't address that, it's very difficult to do productive work. I think helping people to have a voice in family therapy, helping them to be heard by other people in the family can be huge in terms of them starting to feel that they don't need to hang on to that anger. It's a real sense of defeat often in families when I've started working with them. They feel hopeless, and it's really difficult to motivate yourself to start to do something different when you feel like you've lost the game already. And a sense of demoralization. May not feel appreciated by the professionals for efforts that they're making. Child may be doing miserably in their school program. Lots of difficulties. So I'm going to talk a bit about Tina's family here as an illustration of some of these points. Learning some basic facts about FASD is just huge for a lot of parents. Tina's parents were very well educated, bright people. When they finally got to the point where Tina's mother's drinking during the pregnancy was obvious, even though she was never received a formal diagnosis of FASD because the mother never acknowledged the drinking. It started to make sense to the parents, and we started talking about what kinds of challenges teens with FASD may be struggling with. Once they got that, they were able to stop being so angry with their daughter, because now it wasn't about her being willfully bad. It was about her really struggling to comply with the kinds of expectations that they and the community had for adolescent girls. They were able to start relating to her in a more caring manner at that point, which was just absolutely a phenomenal shift for Tina at that point too, because she could stop being a defiant, miserable adolescent girl and actually have the kind of caring relationship with her parents that she really longed for. And her defiance was in many ways a way of protecting herself from the disappointment and anger that she was experiencing on a consistent basis in her life. Parents were able to start making some realistic plans to provide ongoing supports to her. They gave up the notion of giving her up, and as they were making their retirement plans, they included her in their retirement plans. They included the provision for providing caretaking and involvement in her life over the next few years, as opposed to when she's 18, she's out on her own. they also started becoming appreciative of the professional assistants rather than being quite difficult to work with. They started being grateful, they started listening, they started doing their own research as in terms of what kinds of things would be helpful. They became collaborative partners rather than in some ways being as defiant as Tina was initially. So let's talk about good health care for the child, both the physical and mental. So one of the things I think is really important is we need to, as professionals, really need to look at our own attitudes towards living with a chronic disability like FASD. Often it's professionals tend to present with kind of hopeless attitudes or non-helpful attitudes. And Dr. O'Malley refers to a pervasive therapeutic nihilism in the 2008 article that I read. He was talking about professionals refusing to even diagnose FASD a few years back in a certain setting because they felt it wasn't helpful. It was just a devastatingly depressing kind of diagnosis. It was a hopeless kind of diagnosis. So I think we as professionals need to get past that and look at how we can be helpful, how we can purvey a sense of hopefulness, and there are things we can do that will make lives better here and relationships better. And part of that is a team approach. The caregivers and the professionals could be the child therapist, family therapist, psychiatrist, case worker if the child is in care. It could be FASD support people that provide additional training and supports to families. And I think it's really important to also be mindful that we as professionals can overwhelm families with the kind of demands we put on them for regular appointments. So one mom that I've worked with talks about how many appointments she has for the 3 or 4 children she's caring for with severe disabilities. And it took me a while to get that because I'm thinking, I only see them every couple weeks. What's the big deal? But she started listing the medical appointments, all the variety of professionals that are actually involved in their lives. And if you put yourself in her shoes where you're feeling depleted already because one or more of your kids doesn't sleep very well, so you don't have a good night's sleep. You're constantly walking on eggshells because someone can blow up like a vial of explosives not being handled properly. And just the work of raising kids and going to regular kinds of events at school and in the community with your kids can be very overwhelming. So we need to look at that from through the eyes of the caregivers. Going back to Tom's mom, the mom who had lots of her own troubles, but she was also really scared of professionals because she'd had bad experiences in her life of her kids being taken away by children's services at one point. Kids needed to be protected, but from where she sat, her kids were just taken away from her. So it was very difficult to trust. It was very difficult for her to advocate for her kids too because she didn't feel she'd be listened to. And perhaps some of her own experiences earlier on in life too with professionals. So let's talk a little bit about John here. So one of the things that we did in terms of the healthcare system was to arrange some respite care for John, regular respite care that was scheduled in every other weekend. Every other weekend he went and stayed in a group home. That turned out to be a very positive thing for John and his parents. His parents got a break. They could predict it. They could plan things that they could do with their daughter and with each other as a couple, where they didn't have to worry about John. John actually, once he got past the anxiety of a new setting and new people, he actually looked forward to respite because they did fun things there with them on the weekends. So it was a win-win kind of thing. That took a lot of advocacy on the part of John's psychiatrist and myself and the parents to make that happen. And sometimes I think we put up roadblocks rather than bending the structures that are put in place administratively to make important things happen. With John, we also did some meaningful talk therapy. After a while, he decided he wanted to work on his temper. That became his choice. When his parents said, "You will stop being so angry, talk to Willard about it," he had very little to say to me. And once he decided, he actually made use of some of the strategies that I suggested to him. I was kind of wondering, can a young man with his limited capacity make use of talk therapy? But he made some really good use of it, and his parents provided positive feedback to him and to me in terms of how helpful that was. And the other part of the picture for John was his psychiatrist was very responsive to needing to adjust medication and perhaps change the medication regime to better meet John's needs. So it became a team approach there. A little bit more about respite. I'm probably speaking to the converted here today, but I think it's really important to emphasize how terribly important it is for families to have regular breaks where they can recharge their batteries, where they can relax. I think it's important to be regular, that it be scheduled, and also that it be available when there's a crisis too. And our systems aren't very well set up often for those kinds of things, but it's so crucial. And it doesn't always have to be paid respite. It can be respite that's available through family, friends, extended networks for people. And it's important that it be a positive experience for the child too, and that it be presented to the child not as a punishment for your bad behavior, but as an opportunity for you to go and have some fun with other people for a while. I guess going back to Tom, the Aboriginal boy living with his mom in the inner city, one of the things that he did was that he would go and stay with his uncle or his aunt in another part of the city from time to time, as sort of an opportunity for him to have a bit of peace and quiet, because he found his younger siblings could get him really upset. And when he got really upset, he got angry, and he could get violent. Looking at Tina with the older parents, there were times where she went and spent time with her older siblings, her adult siblings, and they were pleased to have her come and visit in the summertime or at Christmas or other times during the year. Gave the parents a break. Tina got some special time elsewhere, and it was once again a win-win kind of situation. And certainly therapy is an important part of the picture for many of the people who are raising kids with FASD, because the children as well as the parents can be experiencing things like depression, anxiety, and compassion fatigue. It can be really important to work with the parents to develop more effective ways of managing the behavior of the child. So a lot of my work with John's family was working with the parents for quite an extended period of time in terms of their own teamwork as parents. John's dad tended to avoid the situations. When he did get involved, he tended to escalate things, become very angry, and make John even more angry, and there was a real risk of violence breaking out there. So we worked on what parts he could manage with John to give his wife an opportunity to not be always on duty, and ways that they could trade off if John's father was starting to feel overwhelmed or getting too upset, how they could signal to each other that it was time for him to step away and let mom take over, and vice versa. If mom was getting worn out, how to get dad to be involved. In the process of doing that, they started rebuilding their relationship as a couple. The constant demands, the fatigue, the depression had really caused a lot of damage to their relationship in terms of the caring and the ability to show caring toward each other and support. So we did work in that area. John's father engaged in some individual therapy through his employee assistance plan, and he found that helpful. Actually, all the members of the family at one point were on antidepressants, and that was really helpful to them in terms of being able to cope more effectively and more positively. And I think I mentioned earlier that Tom's mother chose not to engage in any kind of therapy for herself. She found ways to persevere without formal supports. And the point about that is, we may have an obligation to recommend and suggest, but you certainly can't force people to engage in a process that they may not be ready for. Another part of the family therapy is the strengthening of relationships within the family. And we talked a bit about that in terms of John's parents, the caregivers couple relationship. Important to work on parent-child relationships, help them get past that adversarial sort of thing. So with Tina, we were able to effectively shift that dynamic where Tina felt it was mom and dad against her all the time, mom and dad felt it was Tina against them all the time. We were able to turn that into a more of a collaborative kind of thing where there were troubles that came along, but they became more in the sense of normal teenage seeking independence and having parents less in their life. Although Tina actually was surprising in terms of how much structure she really accepted and actually appreciated from her parents, and I think she actually was able to say that to them, that I don't like it, but I need it. So if you can do that kind of work with a family where they can renegotiate the relationships and start to talk in more positive, helpful ways, that's really important. And another area is the sibling relationships. Often there are siblings who may feel left out, may feel that they're not as important to their parents because of the parents' time and energy is skewed towards the child with FASD. And I think it's important for the parents to acknowledge that and make efforts to devote some time to the other siblings too. And John's sister was an example of that. She started showing signs of depression, so she saw the psychiatrist, and we found an individual therapist to do a bit of work with her to help her kind of get back on track. And in Tom's situation, in terms of relationships, he ultimately went from being a child who couldn't cope at all to working to be his mother's protector. He was the oldest son in the family and grew into a very big man. But he really needed some guidance in terms of how he could appropriately be protective of his mom. One of Mom's partners would periodically come back, and he could be very threatening at times, and Tom needed some coaching in terms of how to be helpful to Mom. Trying to beat up the man wasn't going to be the way to go. He had to, and he ultimately learned that running to the neighbor's place and calling 911 and getting the police out was actually a much better approach for everyone involved than to try to take it in his own hands. But once again, that's a sort of a training kind of thing, right? I mean, his first impulse would be to get violent towards the ex-stepfather. Needless to say, his mother much appreciated his protectiveness, and especially in that he was able to bring in some people with guns and a police car rather than there being blood and stuff around the house after the incident. Another important part of the family work is, I've called it reduce expressed emotion. That term goes way back to the 50s in family therapy, when family therapy was used with the families of patients with schizophrenia. And what that research back then contributed to our knowledge was that when there's a lot of expressed emotion, meaning people yelling at each other, I think is probably a good way, or lots of tears and drama in the family, people with mental health difficulties don't do very well at all. And certainly when you're working with kids with FASD, they have a lot of trouble when there's too much emotion or affect going on. So in the family therapy, it's important to find a way to kind of level that out, not avoid it, deal with it, but deal with it in a way that is going to be helpful, because things can escalate very quickly with some kids and teens. We know that stress and executive functioning, good executive functioning, don't go together very well at all. When we're stressed out, it's awfully hard for all of us to be our best and to think and plan our way through difficult situations. So in the family therapy, it's important to manage the level of affect, help people learn skills for managing the child or the teen with FASD, as well as the caregivers and siblings, and also realizing that stress can be very contagious too. So going back to Tom's situation, when anger flared up, he would get very angry, but much better to do something more appropriate, like run to the neighbor's house and call 911, than to escalate and hurt someone. So a few examples from the families I've talked about today. John's family needed to learn how to more effectively de-escalate his behavior when he became anxious and stubborn and started becoming full of rage. And part of that was Mother was much better at that than Dad was. So they decided that Mom, when it got too difficult, Mom would take care of it. Being in his face and yelling at him was not helpful. They kind of knew that before I told them that, but they didn't know what else to do. They actually made their bedroom into a sanctuary for themselves. He was a very obsessive, difficult boy. He was into everything, and they made their bedroom off limits. And if they were feeling stressed out, they would go to their bedroom, shut the door, and he knew that it was not the time to bother them at that point. And it gave them a sense of control over their environment too, which they were lacking up to that point. Reducing depressive symptoms helped people to have more energy, and parents were more able to handle the situations with some forethought. Going back to Tom, his mother was about 5 feet tall. Her sons currently are, I think, 6, 8.5 was one of them said a while back. They're huge boys. And her own experience of physical abuse from big men meant she was terrified when they started getting large and started being very loud and angry at times. And part of the work that needed to be done there was to empower her to safely stand up to those boys, because they really had a lot of respect for their mom and they were protective of their mom and they were able to handle that. But she really needed to take charge and send them to the room to cool off rather than allowing things to go on. So helping her deal with her own fears and also appreciate that she had far more influence over her sons than she believed at that point. Tina's parents, they responded well to the emotional support that they accepted in therapy, and they quite rapidly regained their previous ability to function well in the home. A similar concept here, creating a holding environment. Therapy becomes a time and a place where we can deal with some of the feelings and behavior that is difficult in the home and elsewhere. We need to create an environment that feels safe enough for people to work on the tough stuff, and where they can learn better ways to manage things and practice better ways of relating in the therapy sessions. And they need to get some support for their efforts so that they can continue with those efforts and build on them. So the family therapy that I do is a really active therapy. I have to be firmly handle acting out behavior when I'm working with some of the families that I work with. Sometimes there's things flying around the room initially. There are people running in and out of the room. It can be very dramatic at times. And I'm thinking back to when I first started doing family therapy. That would have been overwhelming. These days it's kind of exciting, and I feel that I do have the possibility of managing that, which is kind of what I'm trying to pass on to the parents. So you have to be firm. I mean, I've worked with an adolescent girl who, when she gets overly upset, she runs out of the room or she hides under things. And so I've had to do some coaching with the parents, how to manage that, some coaching with the girl on how more appropriately, age appropriately to manage when she's really upset. Because it's just not okay for an adolescent to go and hide underneath a table in a public place. It just doesn't go over well with the other people. I think it's really important for therapists working with families with kids with FASD to bring a fair amount of courage to the situation, because it can be quite dramatic at times. Not always, but sometimes it can be. And you have to show that courage even if you don't feel it. Like Tom's mom, she didn't feel courageous in handling these two big giant boys. But with some coaching, she was able to do that. And then started to feel like she had more ability to manage things in the home. I think it's crucial that we work to engender hope in the people that are involved in the therapy we're doing with them. Like I talked about before, the professionals often have a sense of this is kind of hopeless, we'll do some symptomatic relief kinds of things at best. I think we need to, like with all families when we're working with them, we need to help them see hope for the future, hope that they and their children can do better. We have a responsibility to help shape more appropriate behavior, ways of handling anxiety and defiance and anger in the session, and then to practice that at home and transfer those skills to the home environment. So Tina and her parents made dramatic progress in terms of managing the anger that was really tearing them apart. They really cared about each other, but the anger was destroying that ability to be together. So it's important to modulate the emotion that gets expressed in the session. So creating a sense of order, support for people when they have difficult feelings, help them talk about the feelings rather than acting them out. I think that's so crucial with many of the kids and teens that I've worked with FASD. The feelings get acted out. How to activate the thinking part of the brain so that you can actually think your way and control how you express those feelings. With the understanding it's going to take lots of effort, lots of practice to get really good at it. A sense of each person in the family has a responsibility to work at regulating themselves. It's not all about mom and dad controlling the kids. The kids need to start to develop an ability to control some of that stuff. And mom and dad need to look at their own stuff too and manage that, not just the kids. Important to learn to choose helpful ways of responding to others when they're not at their best. And I talked about 3 adolescents here, and those of us who've raised adolescents know there are lots of days when they're not at their best, and we're not at our best ourselves as parents. If you're working with adolescents who have some of the difficulties that Tina and Tom and John had, they really struggle to manage much of the time. So how do we find more helpful ways to manage those difficult days so that we create a hope that things can improve? And the therapy is also about repairing and rebuilding relationships. So looking at John's parents, there's a lot of repair work needed to be done there in terms of the marriage and in terms of the co-parenting teamwork. Important to give and get support from others in the family. And important to interpret the misbehavior more realistically. So with kids with FASD, you're thinking about it being impulsive or thoughtless rather than assuming that it's a personal comment on you as a parent. That Tina didn't sit around thinking of how she could upset her parents more. She did things without thinking. She did things impulsively. She would sneak out of her bedroom window and meet with boys. That was planned, but she wasn't thinking ahead in terms of the possible implications for her own safety, for the possibility of pregnancy or STD, those kinds of things. And I guess another example that I talked about earlier was Tom's anger at his mother for drinking during the pregnancy. By talking with her about it in therapy, he was able to get past the anger. He didn't hold that against her afterwards. He still wasn't happy about it, but he wasn't actively angry at his mother. And he was able to start making plans for his own life rather than being stuck in an angry place. One of the experiences I've had is often kids and teens with FASD can be extraordinarily perceptive about feelings and what's happening in their family. And some of them can be very good at expressing that in their own ways. And Tina's comment about what's a sexually confident young woman supposed to do, I mean, that was just so out of the blue that she obviously had been thinking about this. She wasn't thinking very straight, but she was thinking, and it opened up the doors to some more discussion. I think it's really important to provide guidance to the family members so they can be helpful to each other, and so they can talk to each other about what is helpful and what they appreciate. So I think above all, we need to work at growing a sense of hope for a more positive future for the family, and we can do that by noticing the strengths in people in the family, help family members to talk about the strengths they see in the others in the family, and to bring in stories of progress, efforts being made, however small, and then we grow those signs of progress. I think we have to come to this with a belief in ourselves of the ability of people to form caring and helpful relationships despite disabilities. I think it's important to work on developing capabilities, not focusing on the disability. And I think we need to support the family members, but we as professionals also need to support each other in the challenging work we're doing with these families. So for a summary, I just want to talk a little bit about where things are at with the 3 adolescents that I've talked about today. Tom is now 18. He's advocating for more independence. He's on a wait list for a group placement out of the home. He and his family believe that he'll function better when he's away from some of his siblings who can be busy at best and can be really irritating to him when he wants some quiet time. He plans to stay in contact and visit his family frequently. He's very good at politely nagging the professionals about making things happen for him that need to happen. And I actually appreciated that because he was good at it. And with the demands on our work time, sometimes things slip. And he makes good use of adult supports. He now has an adult therapist and an adult psychiatrist, and he has kind of taken some initiative there to make sure that the referrals happened and that he's got ongoing care. Tina moved to another city with her parents when they retired. They were going to be living close to extended family. They told me before they left that they had purchased a home that had a suite in it so she could live semi-independently as she got older, but still stay close so they could offer some support and structure to her. And they were all looking forward to that move. Sean was able to function quite well with his family and with the regular respite care eventually. The plans for him were for him to move into an adult group home when he turned 18. He was doing so well by the time he was 17 that he didn't need to continue coming to see us anymore, so I'm not sure what actually happened when he turned 18. And just a summary is that I think family work is an important component of the kinds of supports that we offer to children, adolescents, and adults living with FASD.